welcome all of you to Boston College and to this evening's event in the Park Street Corporation Speaker Series, Health, Humanity, and Ethics. I'm Amy Boesky, Chair of the English Department and Director of BC's Minor in Medical Humanities, Health, and Culture. And with my colleague, Jim Keenan, we direct BC's Park Street Corporation Speaker Series. There's applause. Launched last spring, this new series has the goal to address timely issues in the intersecting fields of health, humanities, and ethics. We greatly appreciate both the corporation and the late Father Quinn, whose generous commitment to civic conversation and the common good aligns with the mission of Boston College. And we're honored to have Ashish Jha with us this evening to talk about Ebola, Zika, and global pandemics, an especially apt topic today, because it's World AIDS Day. Just a few logistical notes. First of all, if I could ask that everybody make sure your cell phones are silenced. Tonight, our speaker has suggested, since we're in a more intimate space, then rather than having a formal Q&A session at the end, he's going to integrate questions and answers into his conversation. So if you feel you have a question, kind of signal that and he'll look out for you. So one of the traditions that the Park Street Corporation Series has gotten started is having an undergraduate introduce our speaker each time. And tonight, Saket Papagahari will be introducing Ashish Jha. Saket is a junior pre-medical student at Boston College, majoring in biology with minors in economics and medical humanities. He's interned and held research assistantships at Harvard's Graduate School in Public Health and at BC, both in the economics department and the School of Social Work. In addition to being actively involved with Partners in Health, Saket has volunteered at Children's Hospital and has held leadership positions for the College Democrats, both in BC and in Massachusetts. In the midst of this, Saket has also been pursuing courses and some graduate courses, various courses in public health alongside the courses he's taking here. Saket, thank you for being here this evening to introduce our speaker.
Good evening, and welcome to the final semester event of the Park Street Corporation Speaker Series. My name is Saket Papagahari, and I'm a pre-med biology student working in public health, and I'm very excited to introduce our speaker. I've been looking forward to this moment ever since I came across Dr. Ashish Jha's work. I first encountered Dr. Jha when, as a naive freshman in college, I took his EDX course, Improving Global Health, focusing on quality and safety. It was eye-opening discovering what it meant to deliver healthcare quality around the world. This past Thanksgiving, my grandfather in India had pneumonia. Instead of prescribing antibiotics, the doctors tried to give him insulin based on their inaccurate diagnosis of diabetes. They continued to write needless prescriptions and order unnecessary tests until my dad called them, the doctors, telling them to discharge my grandfather. Dr. Jha might point out this isn't a microcosm of a village in India, rather reflective of inadequate health systems weakened by lack of physician training and accountability around the world. Earlier this year, when Ebola struck Western Africa, the world held its breath as the disease ravaged communities, killing over 11,000 in a span of a few months. Seeking to learn more about Ebola, I came across Dr. Jha's new course, Lessons from Ebola, Preventing the Next Pandemic, which conveyed key lessons to prevent future health crises around the world, many of which I expect him to discuss this evening. Frankly, Dr. Jha's work has revolutionized global health and the delivery of healthcare from the most rural communities around the world to the mecca of healthcare, Boston. As I follow his work and his blog, his words continue to motivate me to do more in improving health for all, be it halfway across the world or in my own backyard. His work as a leader, researcher, and physician inspire me to fight for healthcare justice. Today, we are privileged to have Dr. Ashish Jha, a giant in the field of global health and health policy, join us. Dr. Jha graduated from Columbia College and attended Harvard Medical School, earning a degree in medicine. He trained in internal medicine at the University of California, San Francisco, where he also served as chief medical resident. He completed his general medicine fellowship from Brigham and Women's Hospital while attaining his MPH from Harvard T.H. Chan School of Public Health. His work continues to inspire students and colleagues pushing us to think about healthcare for all and preventing the next pandemic. As we move forward with our careers as future physicians, policymakers, and advocates, I ask you to reflect on these questions. If we believe that healthcare is a human right, what would that look like? And how do we provide high-quality healthcare even in the most remote areas around the world? Answering these questions will help create lasting health systems that prevent pandemics and provide the highest quality of healthcare for everyone around the world. With that, please join me in welcoming to Boston College, Dr. Ashish Jha.
What do you do after an introduction like that? Thank you, that is very generous. So we have till about 8 p.m. together, and obviously I have a set of slides, and I would actually really love it if we could make this a discussion, okay? I think I will enjoy it more, I suspect you guys will enjoy it more, and so what we're gonna do is I'm gonna look for hands, I'm gonna look for puzzled faces, I'm gonna look for signals that maybe we need to clarify stuff. And then I'm going to also just take pauses along the way. And what I find when I give talks like this is that people are shy in the beginning, and then after the first 2 or 3 questions come out, and you realize that nothing bad happens when you ask questions, I don't get mad, it's all good, then I think the questions will flow. And if I don't get through all my slides, I'm happy to leave a copy of my slides with you guys. So the goal is not get through my slides, the goal is have you learn some stuff, think about some stuff, and hopefully walk away with some new ideas. So I just want to take a minute to talk about why I decided to really focus on Ebola, and why I think pandemic and Ebola and Zika, and why I think pandemics are such an important issue. If you take a step back and ask, what are really big, scary things that can wreak havoc for humanity, that can kill millions of people in short time period? There are some things, right? The big scary stuff. A nuclear bomb going off in a city, right? Awful. A terrible earthquake in a very densely populated area. If you start going through that list, pandemics is one of them. And then you say, which of these is probably the most likely to happen in the next 10 years? It's pandemics. And if you ask, which of these are we spending the least amount of time and resources preparing for? It's pandemics. And I think that's a problem, right? Of all the big scary, we spend, and I would argue you can talk about how much we spend, hundreds of billions of dollars making sure terrorists don't get access to nuclear weapons. Right? If you think about the Bay Area and how much money is spent for making sure that when a big one hits there, that it doesn't cause massive damage and doesn't end up hurting more people than it needs to. Right? And yet, the way we have thought about pandemics has been much more of a sure hope it doesn't happen. If it does, hopefully it'll work out fine. And I'm going to try to argue that that is not a good strategy. I'm going to start with talking mostly about Ebola. I'm going to pick a bunch of lessons that we learned. Ebola strikes me as a particularly important disease. We have studied it very closely. I co-chaired a panel that examined the global response to Ebola. And I'm going to use it as a model for thinking about how we should do better. One of my goals for the evening is I want you guys to walk out saying you really understand what happened in the Ebola outbreak. Everybody in America heard about the Ebola outbreak. There was a lot of fear around it. I want you, one of the things that from a content point of view, is I actually want you to walk out saying, I know. Did I just lose? No. I want you to walk out feeling like, okay, I know what happened, I know why it happened, and I can talk intelligently about it. So that's one of my goals. But also I want to talk about kind of why the system didn't work, etc. So just starting off at a high level, if you look at the Ebola outbreak, the first and foremost thing to think about was that this was a disaster for the people of West Africa. For the 3 countries that were most affected, right? Liberia, Sierra Leone, and Guinea. Why do I say disaster? It seems like a dramatic word. I'll show you the data. More than 11,000 people died. It had incredibly devastating effects on the economy. It had incredibly devastating effects on the entire health system. Probably more people died because the health systems in these three countries shut down, probably more people died, not probably, almost definitely, more people died of other things because the health system stopped functioning in these three countries. Kids didn't go to school for a year. Right? The economy, everything took a very massive hit. So the point here is that the Ebola outbreak was not just a health disaster, it was really a societal disaster. I also think it highlighted 4 points perfectly, and I want to go through those 4 points. The first is we live in a highly interdependent world. Not just interconnected, which we talk about, but interdependent. And there is some pushback happening to this interdependence. A lot of people don't like the fact that we live in a highly interdependent world, and let me explain what I mean by it. Interconnected is certainly things like, you can get on an airplane today, and you can be in Hong Kong in 15 hours, and that's about as far as you can go. Australia, I guess. But the point is that the amount of travel and trade that's going on, we're in one large global community. But interdependent because you could say, well, I don't have to fly to Hong Kong. But so much of what we depend on in our daily lives, the goods, the services, come from all over the world. And there is no walling ourselves off. There is no wall high enough that we can build to protect America from the rest of the world. It's not doable. I think the second point is that we are only as safe as the weakest link in the chain. We are only as safe as the health systems and the capabilities of the weakest countries. Effective health systems are critical. I'll explain a little bit more what I mean by this. But one of the things that the Ebola outbreak highlighted was that it happened to hit 3 countries that had very weak health systems. There are lots of ways of measuring what I mean by health systems. One number to think about, Liberia, right? The country of Liberia had as many doctors as there are cardiologists at Brigham and Women's Hospital. The entire nation of Liberia had as many doctors as there are cardiologists at Brigham and Women's Hospital. Now you could argue that's because we have too many cardiologists at Brigham and Women's Hospital, and I'm happy to have that discussion. But you just get a sense of, well, that doesn't make any sense. And this is the last point, which is we are not ready. And I will, when I finish up, I will hopefully convince you that I think that's true. And I'll just, because that's a little bit of a depressing statement, I will say one thing that's sort of giving away at the end, which is we know how to be ready. We know what to do. This is not a mystery of how are we going to get ourselves ready. And it wouldn't actually cost us that much to get ready. So this is completely within our powers. So those are sort of 4 high-level points, and then I want to jump into the basic facts of what happened with the Ebola outbreak. But I wanted to start off with a framing. Interdependence. When you are living in an interdependent world, you're only as safe as the weakest link. If you think about what really matters is effective health systems. And while we have learned a lot from what has happened in the last couple of years, I'm going to argue not nearly enough. Questions at a high level on any of that before we delve into what happened with Ebola? Let me delve in, and then I hope you guys will have some questions. Some basic facts. The last WHO report, World Health Organization report on Ebola, came out in May 11, 2016. They were kind of doing weekly reports, and then they stopped because there are no ongoing cases. 11,310 people had died of Ebola as of May 2016. A couple of interesting things. Ebola's death rate was 70% among those who were infected and treated in West Africa. Okay, 70% of people who were infected and treated in West Africa, we think. Though some of the numbers are a little funny on that because, well, now there's some data that there were more cases than we thought. But that's the number that most people have sort of accepted in the carefully done studies that have good denominators of who got infected, et cetera. Mortality rate of 70%. That's very high, right? If you think about a disease, a mortality rate of 70% is really high. Ebola's mortality rate was 20% of those who were infected in West Africa but treated outside. 70% versus 20%. And nobody who was infected in America or infected outside of Africa, certainly outside of West Africa, the people, their mortality was close to 0%. One of the things I think we learned from Ebola, Ebola before this outbreak was a very scary disease, right? People had heard of Ebola, it was like the movies about Ebola. And I'll show you the previous pandemic and why it was so scary. We used to think of it as a disease that almost always killed everybody. I think one of the things we learned from this outbreak is if you have a good health system, the mortality rate from Ebola should be close to 0. I actually really believe that. The people, the 20% who died, who were treated up, a lot of that was because they started getting treatment really late in their disease. I think if I were to get Ebola tonight, which I'm hoping not to, the chances that I would survive that case, assuming that I got diagnosed and got care in Boston, the chances that I would survive are close to 100%. Right? Tells us something about the importance of what happened in West Africa. All right, before I go on to talk about past outbreaks, questions about that? Anybody struck by that, bothered by that? Yes, sir.
Just curious, the 20% outside of
Yeah.
West Africa, how large a sample was that?
These are small. All the numbers outside of West Africa are small.
Sure, so,
Small.
yeah.
So how many people were treated outside? 25,
Right.
maybe 22. What's interesting is if you combine everybody who got flown out of West Africa, add the people who were infected outside of West Africa, like the 2 nurses from Dallas, and then compare it to the West African group, even though the numbers are very small, they're statistically different, and it's just clearly numerically they're different, right? And I don't know, is it really 0%? No, if you were like older and sicker and have other health problems, it's probably not 0%. But we're talking about a disease that's highly treatable, highly manageable, which is not how we used to think about Ebola. And I think that's really important. Because it also says one other thing. So Paul Farmer, who you guys I'm sure have heard of and was a speaker in this series, one of the things Paul would say is that 70% mortality, the 11,000 deaths, that's a choice. We have failed to invest in health systems in these countries. There's nothing natural about that. So it's an important point. Okay, I am going to keep going. Let's talk about past outbreaks of Ebola. This was not the first. There have in fact been 24 previous outbreaks. And here's what they look like. The first one, I'm not going to go through all 24 because that would be the next hour, right? I'll just highlight a few big ones. And let's see if I have a, oops, that's not what I wanted to do. That's not what I wanted to do either. Sorry guys, I was actually trying to see if I have a laser pointer on here. All right, I know, it's all good. So the first one, described, there were probably previous outbreaks. This is the first time it was described. 1976, primarily in the Democratic Republic of Congo, 600 cases, 431 deaths. Okay? There was another little one there, then there's more, 315 cases, 254 deaths. There's another one in Uganda. One of the things you're seeing is it's mostly in Central Africa, right? Yes, technically it picks up Sudan, but it's actually just across the board. And lots of little cases popping up along the way. Here's another one, Uganda, DRC, 400 cases, 224 deaths. And then there's that. And that, by the way, was just through 2014. By the time it finishes up, of course, it ends up being much, much more, about 11,000 deaths. So one of these is not like the other, right? And one summary number is across all of those outbreaks, 1,600 deaths. The most recent one, 11,000 deaths. Which of course begs the question, why? Why was this one so different? Actually, let me just list them all. And I'm going to go through these a little bit more after I spend a little bit of time talking about it. So one point, which I guess you could argue is not different, but we think it may have had something to do with why this one spread the way it was, is that it's a caregiver's disease. And you're like, well, what does that mean it's a caregiver's disease? Right. Who gets Ebola? Who gets Ebola? So funeral workers, people taking care of dead bodies. That's one group. Family members taking care of sick people who have Ebola. And healthcare workers. Those are the three main groups. The thing that makes them all the same is that they all touch, hold, infected, sick people. Okay? Now that, of course, is not distinct to this outbreak. That happened everywhere, but I'll show you why I think that played an important role in this one. There's a bunch of other things that happened. There were a bunch of environmental changes, economic development, the national borders. I'm going to come back to all of this after I tell you the story of Ebola and what happened. I'll have a slide that has exactly these same 5 points, and I'll connect the dots. And one of my goals is to have you walk out saying, I know why this outbreak was different than all the others come before. Okay, so let's spend 5-7 minutes on a timeline and disease spread. Are there any questions before I go on to talking about timeline and disease spread? No? Okay, let's do it. I'm going to do this over about a year period. Okay? December 28, 2013, November 11, 2014. We think we know patient 0, the first person who had Ebola. We think we know that because there's been a set of efforts to do genomic testing where people got copies of the virus. We have some data on how much the virus mutates as it spreads from generation to generation, and working our way backwards, people have been able to scientifically guess at what they think was patient 0. Are we 100% sure? Of course not. But we think the disease began when a 2-year-old boy named Emil, right there in Guinea, got the disease and died. And we think he died on December 28, 2013. So I want to bring up 2 points based on this slide. One is, I don't know to what extent you guys can see it, but you should look at where this happened. In Guinea, here is Liberia, really close. I don't know if we have I don't think I have the scale on here, but just right across the border, and actually not that far from Sierra Leone. So it happens that the disease spreads in a spot that's where 3 countries essentially meet. And that ends up being very, very important. Because disease responses are national government responsibilities. And so if something is happening in Guinea, people in Liberia are not paying attention, even if the same people go back and forth all the time because this is one community. Right? That happens. The second point is that it started with a 2-year-old boy. How did he get it? We don't know. There's been lots of speculation. One of the things that we know about the virus is that it hangs out in fruit bats. And fruit bats, this is where the deforestation stuff comes in and climate stuff. There's been a tremendous amount of deforestation in this area. And so people are encountering animals and that they're not used to encountering more and more often. And there's some reason to believe that maybe he ate an infected fruit, which had droppings from a fruit bat, and that's how he got sick. There's a lot of speculation about this. I don't know how interesting or important that speculation is, but I think if it's true, and I think there's good reason to think it's true that it was a 2-year-old, what happens when kids get sick? There was a family wedding. Hundreds of members of a family had come together. The family, some members of that family were from Guinea, from over this parts of Guinea. Other members of that family lived in Liberia. Others were local. It was a family wedding. This boy got sick. What happens when there's a 2-year-old who's got a fever and diarrhea and really sick? how do people deal with kids who are sick? Do they isolate them? Put them in a room for 3 days and say, hope he gets better? What do you do?
Become caregivers and then handle them.
Hold them and handle them. And during a family wedding when lots of stuff is going on, aunts and uncles and cousins and everybody else is like, I'll take care of them for a few hours, right? And so the fact that it is a caregiver's disease, the fact that it was a 2-year-old boy, I think ends up being really important in this. Because what we think is eventually about 30 members of this family died. Because the disease just spread among all these people. Which most of you guys have not had the experience of having kids, but when you have kids, you totally get this. I'll tell you one little side story. It's gonna be a little gross, but I'll tell it. About during the middle of this of the craziness in the fall of 2014, one night I came home from work. My daughter, who's now 9 but was 7, had a fever. She was sick. She had a virus. And she had a really high fever. She was lying in bed, and what do I do as a dad? I lie down next to her, and then she basically threw up on me. Right? This happens. You guys have all done this to your parents. This is what happens. Parents and kids and the moment she did that, first I was like, oh great, I have to change. It was fine, and I helped her get cleaned up. But it hit me. She had a run-of-the-mill virus syndrome. But if she had Ebola, which obviously she did not, I was done. I would have gotten infected at that point. It's very hard to take care of somebody who's sick with Ebola as a family member and not get infected, right? So the fact that case 0, as we think of the first person who had it, was a child attending a family wedding, we think is really important. And the fact that it was right at the borders, we think is really important. I have a bunch more, but I'm not going to spend this much time. I just wanted to lay the first one out because I think it sets up the story. Yes?
As a caregiver's disease, do you see it disproportionately affect women?
It's a great question. It's a great question. Why don't I know the answer to that question? I have not seen data that there's a huge gender difference in deaths. I think what happens is you can imagine in families that women might die first, they get infected first if a child is sick or another family member is sick. But eventually it ends up knocking out the entire family. But you would think so, right? You would think there would be more women. And I feel like I've seen data on this, and I don't remember seeing a big gender disparity, but I don't know for sure, so I'm sorry, but I'll look that up. It's a good question. Any other questions or thoughts? Okay, now I'm going to march for the next 6-8 months and show you data. And I want to make a couple of points about what the global failure with Ebola was. Okay, this is just based on the data we have. Obviously, there was stuff happening in between. So remember, last one here, this is the end of 2013. We didn't know. Nobody knew that this happened, right? It's only in retrospect that we found that. Okay. The first time we become aware as a kind of global community that there is Ebola here is March 2014. 3 months later. That's interesting. 3 months have passed, and people didn't pick up that Ebola was spreading. And this is when Guinea confirms that this previously unidentified hemorrhagic fever that has killed over 50 people is Ebola. And there's one suspected death in Sierra Leone. But the point on this is look at the spread, and you get a sense that this is not localized to one area. I'm going to keep going. This is just a week later. And now you can see it is really starting to spread across a large. So this is still in Guinea. There's just that one case in Sierra Leone. All of this is Guinea. And now you're starting to see a couple of cases in Liberia. And I think what this should make people realize, and this is when Liberia for the first time says, we have cases. And what I often say is, at this time, we was at one case in Sierra Leone, but we thought there's nothing happening in Sierra Leone. That one person died, maybe they picked it up here. And one of the points that we make in retrospect is if there's a bunch of cases here and a bunch of cases here, the chances that it skipped this entire country are probably pretty low. Just so we're not picking it up. Here is to me one of the big failures. MSF, Doctors Without Borders, right? Let me just be very clear because I segued in a way that you can potentially misunderstand. MSF was one of the heroes. Doctors Without Borders was a phenomenal hero in this disease. They had people on the ground, and on March 31st, 2014, they had a public statement. They said this is an unprecedented spread of Ebola, and they're sending 60 more staff members to Guinea, and by this time we have 130 cases and 82 deaths. Okay? March 31st. Here is the World Health Organization's response. The next morning they come out and they basically say, nah, MSF is overstating it. They're doing this to raise funds. There really is no problem. And I'm happy to talk about why WHO did that. You want me to deal with it now? Sure.
Briefly, just to give us to understand what happened there.
Yes.
Please.
So what happened was the countries, Sierra Leone technically didn't have any cases. You know there's one person that died, but didn't have any spread. Guinea and Liberia said to WHO, just calm down. Don't advertise it. Play it down. Because we're worried about trade, worried about travel, we're worried about companies pulling out, and WHO basically come along. The regional office of WHO basically went along. Yes?
How much of the spread that you saw like the week after Guinea announced the first case was just due to them kind of going back through it real
Correct. Great point. Yeah, so the question was that really that much spread in a week, or was it just people now going, oh, we have Ebola, going back and retesting people? Yes. So it's much more the latter. Once you've identified the disease, then you can go back and start looking at that. Okay. I'm going to keep going. Here we are now we're in May. This is the first time Sierra Leone has acknowledged that it has cases. Just take a look at the numbers. We're at 258 cases, 174 deaths. We're a month and a half after MSF said, this is unprecedented, we need help. Here it is a month later. MSF is still the only major aid organization treating Ebola, and MSF's director of operations, Bart Jansen, says, we have reached our limits. We as an organization can't manage this anymore. We don't have the staff, we don't have the resources. We're going to continue going full speed, but we can't ramp it up anymore. We don't have anybody else to call in. Look at the number of cases, number of deaths, right? 528 and 337. And still no response from the world. At this time, so this is one of the kind of revisionist history, people have gone back and said, oh, nobody knew it was this bad. This was making it to the front pages of the New York Times. When something's on the front pages of the New York Times, you don't get to say nobody knew about it, right? It was starting to become clear. So this is MSF saying it's out of control, calls for massive resources, about 350 deaths. And in July, the disease for the first time showed up in Nigeria, in Lagos. If I took the dot off, you'd see the word Lagos there. Major city in Nigeria. And this was terrifying to people because what this meant, Lagos is a major travel thoroughfare for people in Africa going across the world. What people worried about was very densely populated city, major travel kind of hub, and if the disease starts spreading here, it's going to basically take over large chunks of Africa, and it's going to get very big very fast. And Nigeria actually did an unbelievable job of public health contact tracing, finding everybody that came in contact with people who were infected, and essentially shut it down. Within 3 weeks, a bunch of people died, but within 3 weeks, this disease got under control. Basically reminding all of us that basic public health measures work. They didn't have any fancy new drugs, they didn't have any fancy treatments, they used standard public health measures, and it actually worked really well. Questions, thoughts on any of that? We keep going, yes?
What's the typical timeline
Great. Good question. Timeline, let me give you the kind of, if I get infected today, I have basically 3 weeks is like the outer limit of when people start showing symptoms, so the incubation period can be as long as 3 weeks. We think typically it's 6 to 9 days. So by day 7, day 8, people start exhibiting symptoms. But the first point is first 5, 6 days, there are no symptoms. Or first 8 days, there's no symptoms. And then once you develop symptoms, of course, it has everything to do with whether you get the right treatments and how you do it, et cetera. And the key to remember is that when you don't have symptoms, you can't spread the disease. So if you don't have fevers, you're not vomiting, you don't have diarrhea, you're not bleeding, you can't spread the disease. So that means if I got infected tonight, you guys would be all totally safe hanging with me tomorrow. A week from now, maybe a little less so, right? But you can't spread this when you don't have symptoms. All right. This is when WHO finally gets engaged. August 7th, 2014. By this time, there have been 1,200 cases, 670 deaths. We, again, by the way, we think most of these are underestimates because once we've gone back later, we think there have been some number more. And finally, on August 7th, WHO comes out and declares something called, so they have a first meeting actually, and the next day, they declare something called a FIGHT, a public health emergency of international concern. That's what WHO uses when something serious has gone on. It's multinational outbreak of a disease. It mobilizes resources. It gets people focused, okay? The problem was that it was in August. And what happens in August? It's a little vacation time. A little tough time to work too hard. So, yes, they declared a public health emergency, but there was not much that happened after that. Sort of, things kind of started ramping up slowly. And the day-by-day numbers are climbing very high because we're actually finding more cases we're identifying. We're at 1,000 deaths by this. MSF President Joanne Liu, again, unbelievable person on August 21st says, actually by that time, 1,400 are dead, we need help. They meet again, July 16th, they say it's still an emergency, and by this time, the world has really taken notice. And we think that these are kind of, again, underestimates. We think it's much more than that. And a couple of things to just point out. September 18th, they created something called UNMIR, the United Nations Mission for Ebola Emergency Response. It was basically a coordinating agency by the United Nations that said, we're going to coordinate the world's response to Ebola. What is WHO's role in disease outbreaks? To coordinate the world's response. So when the United Nations created its own entity, that was basically the United Nations saying, we don't think WHO can do the job. Right. All right, I'm going to just quickly finish up here. By November, there are lots of things happening here, this entire area. And a couple of these dots in these places are mostly people who've been taken in. There was a Spanish priest, there was a Scottish nurse, here's Dallas, and a couple of nurses from Dallas. There's a physician in New York, you guys remember all that. Those are individual points. They look really big because we made the dots the same size, but all the action is here. This is where the disease was. I'm gonna come back to why this was different and reiterate a couple points, but let me ask, what questions do you guys have about that time span? By November, December, the US military is in, building Ebola treatment units. Lots of NGOs have come in, non-governmental organizations have come in, lots of resources. I think fundamentally the thinking is when between March 31st, when MSF first said unprecedented outbreak, we need help, and September, there was 6 months. That is a long, long, long time to wait. Let me just make one quick thought and I'll come to you. The Spanish flu of 1918 that killed tens of millions of people around the world. In the second wave, there were multiple waves. we think from the time that it began to its peak in terms of number of people who were dying was about 6 weeks. We don't generally have 6 months, 8 months to respond to a pandemic. It's not how the system works. You gotta have response in days to weeks at the latest. And then we just got the timeline completely wrong. Yes.
What was the change in global public response following the cases in America?
Well, the cases in what?
In the United States.
Yeah, so the world made fun of America because, I mean, you guys remember the level of fear, right? People were like, I'm not going to the sandwich shop in which he ate 3 days ago. You may not want to go to that sandwich shop for other reasons, but it has nothing to do with Ebola, right? Like, the point was, there was a lot of panicking, a lot of fear, a lot of calls for shutting off trade and travel and no more flights to West Africa. Remember the nurse who came back from West Africa, and Chris Christie, in his brilliant public health intervention, decided to quarantine her, right? Those are exactly the wrong things to do. They're actually really harmful, not just for the people of West Africa, they're really harmful for us. I'm happy to explain that more, but they were bad for us. There was a lot of that. One of the things I have said, and I at times have been critical of our president when I feel like he gets the policy wrong, he got the policy totally right on this. Despite all of the political pressure to do dumb things that feel good, he held strong, kept the flights going, kept letting people, Americans, come back when they had served in West Africa. And it worked out fine. It worked out well. But there was a lot of fear and a lot of overreaction. Yes?
How do you think this all could have changed if there was a big response in March instead of 6 months later?
So I always say that instead of 11,000 people dying, it would have been 500, 300, maybe 1,000. But that still means 90+% of people who died unnecessarily. And they died because we were too slow to respond. Yeah.
I'm curious, did Nigeria have a relatively stronger public health system in place than the other two countries?
They did. And here's what's interesting. There's some debate about why and how. And we think part of it, and again, reasonable people disagree on this, so just hear me out. But I think there's good reason to think part of it is because of PEPFAR. So PEPFAR is the President's Emergency Program for AIDS Relief. It is a program that the US government has been helping pay for drugs and infrastructure. And Nigeria actually used some of the PEPFAR dollars to really build a very good surveillance system that was not designed for this, but was repurposed for this. Some people say, no, that's not exact. But anyway, the point is, yes, they had a better public health system. Yes, they had made better investments. And I do think there's some reason to believe that some of it is because they had just been more mindful and purposeful of how they had used some of the dollars they had coming. So one of the things we all looked for was sort of the magic bullet, the drug. Was it going to be this, ZMapp and all the? They used just standard public health stuff. Isolate, treat people when they're sick, contact tracing, find people who've been in contact, low tech. Right? You don't need lots of doctors, you need community health workers, you need public health nurses, you need, but low tech. Let's again talk a little bit about why this one was different. So I told you about the caregiver's disease. I think because it started with a 2-year-old, we think that actually probably mattered a lot. Environmental changes, there's been a massive amount of deforestation in the area, which is why we think it was the first time we saw this in West Africa. Economic development. Now, why would economic development do this? And there's a point I'm going through this list. So economic development means more roads, faster travel. If you go back to the original outbreak in DRC, it was in a pretty rural area. Most of them have been in pretty rural areas. That's where they tended to start, and that's where they tended to stop, because travel is hard. But when you have economic development, you build great roads, all of a sudden people can go 500 miles in 2 days. You can spread the disease far more quickly. Economic development, by the way, is a good thing. I am not saying, oh my God, shut it down, no roads, no bridges, everybody's got to go back. But understand that the consequences of economic development is more interconnectedness, more interdependence. Whoa, going way too slow. I'm going to speed up a little bit. National borders we talked about, retail systems. Okay, so let me just spend 5 minutes and kind of run through a bunch of stuff. So if you look at the 4 phases of the thing, we did in our report, kind of broke it down. Why did it take 3 months from the first disease to the first person dying, to the first time anybody identified this as Ebola? Remember? December to March. These countries didn't have health systems that could make the diagnosis. They didn't have any labs, or very few labs, right? Inadequate monitoring of commitments to build capacities. What I mean by this is all of these countries, all countries in the world have made a commitment to having a surveillance system. We don't really have much of a monitoring program like this. Actually, I'm going to come back to this in a bit. The second time period after it became obvious that it was Ebola, there's no incentive for early reporting. If you're the Minister of Health of Liberia, and you want to make a big deal that you have an Ebola outbreak, you think your Minister of Commerce is happy? You think your president is saying, great, tell the world we have Ebola? How many people think that's a good career move? What's the real response? It's a few cases. It'll be fine. Right? And it's totally logical. Like, these are not bad people. These are good people trying to manage a complex situation. And so then you say, oh yeah, maybe it'll sort of peter out, it's okay. And then the disease keeps getting worse, and you keep getting into denial. So there's no incentive for early reporting. There's no incentive for a country to say, we have Ebola. Right? When they figure out they have Ebola, they have very little ability to actually go target what's wrong. I've talked about WHO sort of mobilize global attention and assistance. Once everybody kind of knew, so it went from like the countries knew to now the world is paying attention, then WHO starts doing things like saying, okay, we really got to start sending people in. And nobody listened. Then they said we shouldn't have trade and travel bans, and countries didn't listen. There was a very slow global operational response. Again, I'm going through a long list here because I want to get through. Unclear responsibility for coordination. So now Canada's sending in aid, and Australia, and the UK, and Germany, and France, and they're not talking to each other. And America's got like NGOs and the American government, and no one's talking to each other. You need coordination. And then the issues around, well, we did have some drugs for this disease, who was going to get it? All right. Last point, I actually want to take a minute to talk about this. This is really important. So in November of 2014, I was in Geneva, and I was moderating a panel at the WHO on what went wrong, kind of early days of getting a sense of what went wrong. And on my panel was the Archbishop of Guinea. And in his talk, in his opening, his remarks, and even in it, he used one word over and over and over and over and over again. And that word was trust. Or the lack thereof. The lack of trust that people had in their government, the lack of trust people had in their figures of authority. People didn't trust them. And so when the Minister of Health or when government officials showed up and said, don't bury your dead that way, because you're actually spreading the disease, people didn't trust that advice. Right? They came and said, if you have somebody who's sick, take them to the hospital. Seems good advice, but the hospitals were in such bad shape that when people took them to the hospital, they all died. So then people started getting the message, actually don't take them to the hospital because they all die in the hospital. Right? So I think a major part of what turned the disease around was people realized they actually had to figure out how to engage with the community and how to build trust. And building trust in the middle of an epidemic is really hard because people are dying left, right, and center. And I think if we're going to think about it, there's a whole bunch of policy prescriptions about how to prevent the next pandemic. I don't have the line in there about build trust, but that's probably the line that needs to go in most. There's a bunch of other issues around how money flows, et cetera. I give the global response a D-. So people say, well, why not a failure? Because we got a couple of things, right? Lagos, we eventually got the disease under control, but the bottom line is you can easily argue it's an F. This should have been a 300 people died at most, 500 people died at most, and it was 11,000 people died. And it wrecked the economy of 3 countries. Have we done better with Zika? I think the answer, by the way, because I want to get to sort of where we go next. Remember Zika, and we've talked about this, is spread by a mosquito. It's also spread by people, people to people and mosquitoes to people. I do want to just, because there was a question about this earlier, I want to just remind everybody what Zika causes. 80% of people have no symptoms. Some proportion of people just have a fever and a rash. 1 out of 1,000 adults get this neurologic thing called Guillain-Barré syndrome, which can be serious. The real scary part of Zika is the impact on babies. And I say babies because some of it is fetus, maternal-child transmission, and now we're starting to get some evidence that even when newborns get infected with Zika, there's probably some substantial neurologic issues. This outbreak started in Brazil, or first seen in the Americas. Again, all these things have long histories, right? It was in French Polynesia, et cetera. But these things started in the Americas in March. There have been a lot of cases. But remember, 80% of people don't even know. But we have 2,300 confirmed cases of congenital syndromes associated with Zika virus infection in the Americas. And that number is I think, probably, again, an underestimate. That's an incident rate. If the question is, have we done better? And again, I'm going through this fast because I want to kind of finish up with a few points. I would say the answer is yes. With Ebola, we waited a long time. I think that with Zika, it was not only timeline a little bit faster, but well before a lot of the devastation kicked in. I think WHO learned that lesson. Over the last couple of years since the Ebola outbreak, they've created a new emergency response unit. Right? So they had all these people in different parts of the offices of WHO. Now they're under one unit, and they've actually been doing a much better job of coordinating the response. I'm actually going to skip through some of this. And then the other thing where I think we've made progress is R&D. And this is actually too big a conversation. So let me actually take a minute and talk about research and development, and just ignore my slide. Research and development, this is a really important thing. We had no drugs for Ebola. Why did we have no drugs for Ebola before the outbreak? Did we not know that Ebola existed? Of course we did. 24 outbreaks. There's no market for making drugs for Ebola. Any pharmaceutical company that decides to spend hundreds of millions of dollars on making a drug, their CEO is going to get fired. Because there's no financial incentive, right? Because it was happening for two reasons. It was rare outbreaks, poor people. Even common outbreaks in poor people is a real problem from a market point of view. Because if poor people can't afford drugs, you're not going to make the drugs. Well, we all think that's a problem. We do not want to live in a world where we will not make drugs or treatments or diagnostic tests for diseases that affect them. Right? We all agree with that? For a variety of reasons, from moral reasons to interdependence issues. This is not a new topic that got first brought up to them. What I think has happened is with Ebola is the realization that we can't keep going like that anymore. Okay? We can't keep going on a trajectory where we just invest in the 19th new medication for high blood pressure because we know we can sell it in the US or the UK and do nothing for Ebola and Zika. And so we have started seeing, I think, progress on this. And that's what my last slide was. We're starting to build these entities and we're starting to put a little money in and we're starting to move on this topic. And I think that's good news. But I do think this is the bigger point I want to make, which is, so what has happened from Ebola, I'm going to summarize in the interest of time, is WHO started, at least with Zika, moved a little faster. they've started streamlining some of their own independent problems that they had of disorganization. And they have started pushing forward on research and development. That's good. Those are like 3 big problems that they have started moving forward on. The big problem here in my mind is it's not that or enough. Because basically, the lessons from this are a couple of things, right? If you think about what we learned, we have to have, and I only have a couple more slides and I'll go to questions. Things that we learned, we need national commitments to building surveillance and response systems. The reason why Nigeria did as well as it did is because it had a national surveillance and response system. Now, technically, all the countries in the world have made this commitment. It's called the International Health Regulations. I mentioned that earlier. There's just no monitoring of it. Right now, what happens, WHO sends out a survey every year to the health minister saying, you got one? And they all write back saying, yep. Right, I'm being a little simplistic, but I'm actually not being that simplistic. It's pretty close to proof. We also need global commitments to health, because you can say to poor countries, you need to have this. And they say, sure. We don't have the resources and we don't have the technical capabilities. So we actually have to have a global commitment to health. I didn't get into all the ways in which WHO really failed, but I think we need a WHO that can be much more effective. I'm happy to explain why there was that 6-month delay. It was a cultural failure. We need to fix that. We've talked about research and development. And then financial commitment that matches the problem. Let me just make one kind of final point on this. The Institute of Medicine in the United States, this is this very august body, put together its own evaluation kind of report of what happened with Ebola. And they said the world basically spends about pandemics cost the world about $60 billion a year. Because disease outbreaks happen, but all the kind of economic and other costs, $60 billion. And we need to spend about $4 billion a year in order to prevent that $60 billion of spending. Right? The cost of pandemics is $60 billion. It'll cost $4 billion to prevent it. The problem is that $60 billion is kind of spread out over everybody, and $4 billion everybody can know when it's coming out of their pockets. And so nobody wants to put in the $4 billion. So I said the research and development is starting to ramp up. We're starting to spend tens of millions of dollars. We need to be spending about $1 billion a year. That was their estimate. $1 billion a year, by the way, may seem like a lot of money. Anybody know how much money we spend on healthcare in Massachusetts? How much do we spend on healthcare in Massachusetts in a given year? About $50 billion. So what Massachusetts spends in a week is what the world needs to spend on research and development to deal with preventing the next pandemic. This is not a crazy big number. The whole world, right? What Massachusetts spends on healthcare. Looking ahead, last slide. I think the world is not ready for the next pandemic. We know what the problems are. We have begun to do stuff, but we're really early on. I think the global community has heard the call. We know what to do to be better prepared. And I'll lay those out. Let me just remind everybody. Countries need to have a surveillance system. We need to help poor countries that can't do it by themselves. We need to invest at least $1 billion on research and development. We need independent tracking, so we're not tracking by sending people a survey saying, do you have it? Yes or no, right? That's not a good way to do it. And you need a World Health Organization that is able to push the world forward. That's it. It's not a crazy long list. It's not undoable. It's certainly not financially $1 billion for R&D, and we think about $3 billion for everything else. The last point here is a lot of people have been sort of saying, well, who's going to do all these things? Is it WHO? No. Countries, all the countries say, yes, we should do this. And then they say, and we'll wait for this other country to do it. So this is the free rider problem. If WHO becomes really effective, who benefits? Does America? Yes. Does the UK? Yes. Does Liberia? Yes. Everybody benefits. So who wants to pay for WHO to be more effective? And everybody's happy to have somebody else pay for it. Right? So I think we're only gonna really make progress if individual people, organizations put pressure on their governments to say, we've gotta come up with the resources, we've gotta create the accountability. Because I do think at the end of the day, the responsibility is ours. I don't see anybody, any force out there that's gonna get all of this done. Unless there is public pressure to move forward with this. All right, I'm sorry I kind of flew through the last part. I realized I had been going too slowly and I looked up at the clock. I'm fine to keep going for a few minutes. It's 8:04. Do you want to cut us off or do you want to go for another 5-10 minutes? Okay, I'm delighted to go, keep going. I'm happy to go back to any of the points I made earlier. Let's start with the gentleman in the back and then we'll come up.
So you talked about preventing the next global pandemic. So,
Yes.
like in terms of like based on your own research into this, what do you think like any like emerging like infectious diseases will be like within, like particularly what emerging infectious diseases will come about?
What do I think will be what are the next, which diseases?
Yeah, will be like coming out in the next 5 to 10 years.
So, can I punt on that question by giving you the following answer? This is how you dodge a question. If you had asked any expert 5 years ago, what do you think the 2 diseases are that the world is going to be talking about in the next 5 years? I don't know anybody who would have said Ebola and Zika. Nobody I know. So I'm saying I don't know. Like yellow fever is really a problem right now. Will that become more global? Maybe. But like the bigger point is you shouldn't listen to anything I say. Because, I mean, maybe the other stuff. But on predicting the next virus, it's very hard. Because the stuff that's really predictable, we have systems in place. And the point I argue is you can't predict, you can only prepare. Because you can't predict. Because if we knew it was going to be yellow fever, we'd ramp up our vaccines for yellow fever, we'd build in a surveillance system for yellow fever, we'd be ready. But the problem is because we don't know, we don't make investments in the basic underlying stuff. Does that make sense? So I'm not trying to punt on your question, I honestly just don't know. Okay?
You mentioned that the countries would, potentially develop more robust surveillance systems
Yep.
and external monitoring. But what will incentivize people to accurately then report what they know? Because we have been examples of China and SARS and other examples
Yeah.
of this. They kind of silenced some of the initial reporting.
Yeah.
What's a potential policy solution there?
Yeah, it's a really good question. And if I had an easy one, I was gonna say I'd be a rich person. I'm not sure I'd get rich off of that, but at least it'd be better off. But here's what I think. So the United Nations is building a new mechanism for monitoring, independent monitoring. I am deeply skeptical. Not because I'm like anti-UN. It's very hard for the UN, which is made up of member countries, to monitor member countries. It's very difficult. So I think an independent monitor has to be truly independent of governments. Has to come from the outside. And so actually, a group of us, me at the Harvard Global Health Institute, with about 5 or 7 institutions from the global north, global south, around the globe, are trying to create a consortium of basically universities, think tanks. We know how to collect data, we know how to analyze data, we're independent of governments. To say we are going to be doing the tracking and monitoring and putting out a grade every year of every country and how well they're doing in meeting their obligations. I'm confident that there are a large number of countries from which I will be disinvited for doing anything in the future, but somebody's got to do it. And the US government isn't going to do it. The UN is going to try, but they're going to have a very hard time. Because ultimately, you got to be able, so the whole point of independent assessment is you got to be able to call people out. Right? And that's very hard. Yes?
So you talked about how research and development is getting a little better, but Ebola was a big thing back then, but like now the average everyday person doesn't think about it all the time. So
Yes.
do these things kind of peter out in terms of research and development? Do they get really interested and then it just like kind of blows over? Like,
Yes.
How often does that happen?
That happens all the time. The problem is, if I was giving this talk about what we need to do while the Ebola outbreak was still raging, everybody would be like, oh yeah, and let's go do it. But the interest wanes as soon as the disease goes away. And so when I put together the panel that I co-chaired on the global response, one of the things I said, we got amazing people, like really some of the smartest, most brilliant people around the world. And what I said to all of them is nobody needs to be on another panel. Nobody needs to be a co-author on another 20-person report. I still want you to do this because I promise that we are not going to stop when the report is done, and we are not going to stop when the outbreak is over. And so I think part of it is creating a group of people who, when no one's talking about Ebola anymore, saying, we're not done on building the research and development infrastructure for the next disease. We're just not. We're not going to wait until the next outbreak and go, oh my God, we don't have enough R&D, and start this train all over again. And so there's a group of us who have decided that like part of what we're going to do during this lull, not really a lull, Zika is still going on, right? And a real issue. But when the public is not, this is the moment to drive this. So we're going to try. Am I going to be successful? I don't know. It's not me, it's the whole group of us. But it is very hard when the public is not paying attention.
Do you think, should the R&D be on individual pathogens? Or are you talking about R&D that is something else?
So this is a good question, and there's a bunch of, there's a debate on this. There's a thing called CEPI, the Coalition for something, Elimination Prevention, I can't remember, CEPI. Actually, like, know people who run it, but I'm blanking on it. But it's basically a coalition to try to do R&D. And what they're doing, which I like the people who are running it, they're really smart, is they're saying, we're going to target 11 pathogens that we think are likely. And it's based on WHO's assessment of what are the 11 pathogens that are the most likely. So there is that list that you asked about, the gentleman in the back, and that's what they're targeting. And they're smart people. They understand that there's a very good chance that the next outbreak won't be one of these 11. And they're saying there are two things. First of all, there's actually a good chance it could be one of the 11, and so we'll have vaccines against them. And second, we'll hopefully learn so much about these kinds of pathogens, our knowledge about how to build a vaccine relatively quickly for diseases will advance. So even if it's not one of these, we'll be in better shape. There are other people who say, I get that, but you should actually just invest in the platform, in building the platform for vaccine development, whatever the pathogen. My take is we should do both. I mean, these are small dollars compared to the size of the problem, and I don't think we should have to choose, but we're going to probably have to make choices because we're not going to make the investments that we need to. Couple more. I saw one more hand over there. The person, maybe not. All right. Thank you all for listening. That was a great discussion.
This is a great way for us to conclude this semester with our work with the Park Street Lecture Series, and your presentation takes us to the future. So, the next time we'll convene will be on January 26th, when we have James O'Connell coming from the Boston Healthcare for the Homeless Project. And he'll be here with us, and we hope you will be as well. Again, thank you.